Today's journey has passed endometrium, follicle monitoring, and poor responders. Now the next station is ahead. Each infertile patient is different, and we cannot have a standard protocol for them. So it should be a tailor-made person. So for this next session, I would like to invite Dr. Punit Khatri. The topic is the real art in ART, choosing the right trigger. Dr. Punit Khatri is an undergraduate and postgraduate from BGMC. He had an endoscopic stint in France. He's a great academician, presented paper in national and international front. An all-rounder, OBS, gynec, sonography, laparoscopic, and IVF. So to shower some rains on this human farming, I like to invite the king of Mandvi, our own Malik, Punit Bhai.
Welcome, Punit. And at the outset,
Madam,
we have to thank you.
Thank you
that
for
had
your
given-
kind compliments in front of such a big lions and tigers, in the field of ART. Thank you, ma'am. Good afternoon, everyone. Honorable chairpersons, respected seniors, dear colleagues. I am going to speak on the real art in ART, and that is choosing the right trigger. જીતુભાઈ હવે શરૂઆત તો આપણે સ્ટેપ તો એડવર્ડથી જ થશે આમાં બી ક્યાં જીતુભાઈ નથી ગયા એના પર છે ને જીતુભાઈ આના પર તમે ડિટેલમાં પછી પ્રકાશ પાડે તો સ્ટેપ તો એન્ડ એડવર્ડની જે પેલી જે ફર્સ્ટ આઈવેફ બેબીની કોન્ટ્રોવર્સી છે એમાં જીતુભાઈને વધુ ઘણું નોલેજ છે સો વેન ધ વર્લ્ડ's ફર્સ્ટ IVF baby was born, Louis Brown in 78, it was a result of a single oocyte retrieved in a natural cycle. In that era, the success rate of ART was not even 1%. But now, with better understanding and knowledge of the hormones responsible for reproductive endocrinology, the success rate of ART has reached up to 50, 60 or 70%. Successful ART outcome depends on the complete knowledge of endocrinology and the hormones responsible for folliculogenesis, ovulation, and implantation. Proper selection of stimulation protocol, proper selection of the patient, and right trigger for the right patient. So our motto should be controlled ovarian stimulation with retrieval of maximum number of mature oocytes leading to maximum number of good quality embryos, and without the complications like ovarian hyperstimulation, torsion bleeding, or infection. And trigger has got a pivotal role along with the stimulation. It is very essential to understand the physiology of ovulation. Up till now, in the most of the textbook we studied, the authors have emphasized the importance on LH surge only. But recently, the researchers have found that the FSH surge is also equally important along with LH surge for the final oocyte maturation. So ovulation is basically a physiological process which mainly involves the action of FSH and LH releasing from anterior pituitary, and each ovary retains 1 to 2 million of primordial follicles arrested in prophase of the meiosis 1 till the time of puberty. At puberty, FSH and LH start secreting from the anterior pituitary. FSH and FSH and LH act on the primordial follicles, complete the meiosis 1 and start meiosis 2. And FSH acts on granulosa cells which secretes the estrogen. Rising estrogen level induces the mid-cycle LH surge. So LH surge induces a loss of gap junction between oocyte and cumulus cells leading to cumulus expansion and germinal vesicle breakdown with resumption of meiosis and luteinization of granulosa cells. And rising progesterone level induces the concomitant FSH surge or FSH peak. The FSH peak has got very important action. FSH increases the LH receptors on granulosa cells. It also increases the synthesis of hyaluronic acid that facilitates the expansion and dispersion of cumulus cells, allowing the oocyte cumulus cell mass to become freely floating within the follicular fluid, which becomes less resistant to the follicular aspiration in ovum pickup. So what are the triggering options available in day-to-day clinical practice? Number one is human chorionic gonadotropin, that is known as HCG. Number two is gonadotropin releasing hormone, that is GnRH agonist. Recombinant LH, which is not commonly used in the day-to-day practice. Dual trigger when we combine HCG and agonist. Double trigger when agonist trigger is followed by HCG. And kisspeptin. Kisspeptin is also not used nowadays in the practice. So commonly used trigger nowadays are HCG and agonist in form of alone or in combination like in dual trigger or double trigger. So how the HCG works? HCG acts as LH surrogate because of its structural similarity between the alpha subunits of both the hormones. HCG binds with the LH receptors and induces the ovulation. It has a luteotropic effect, means it leads to survival of the corpus luteum. And how agonist trigger works? When we give agonist, it blocks the GNRH receptors. Agonist trigger block the GNRH receptor on the anterior pituitary, which leads to initial flare-up in form of FSH and LH surge, which leads to ovulation, and it is immediately followed by the downregulation, which leads to immediate breakdown of the corpus luteum or luteolysis. How kisspeptin works? So kisspeptin is a neuropeptide. It's basically produced from the neurons located in hypothalamus, rostral periventricular area of third ventricle, and arcuate nucleus. So these neurons project into the hypothalamus, stimulate the GnRH releasing neurons in the hypothalamus via the stimulation of KIS1R receptors. They stimulate the release of GnRH from the hypothalamus, which in turn stimulates pituitary to release FSH and LH, and FSH and LH stimulate ovaries to produce the gonadal sex steroids. So rising level of gonadal sex steroid will stimulate the kisspeptin receptors in the third ventricles, but inhibit the kisspeptin neurons in the arcuate ventricle, arcuate nucleus. So this is the mechanism, basic mechanism behind the positive and negative feedback mechanism regulated by the kisspeptin neurons. So if we understand the regulation of HPO axis by endogenous kisspeptin, the use of exogenous kisspeptin for the ovulation trigger sounds the promising option for the future of better triggering option in the practice of ART. So if we compare the LH surge between natural cycle, agonist trigger and HCG trigger. In natural cycle, there are three phases of LH surge. A rapidly ascending phase of 14 hours, a plateau of 14 hours, and a descending phase of 20 hours. So total duration of LH surge is 48 hours in natural cycle. And when we give agonist trigger, there are two phases of LH surge. Short ascending limb of 4 hours and long descending limb of 20 hours. So total duration of LH surge in agonist trigger is 24 to 36 hours. And now when we give HCG, what happens? HCG is a three phases of LH surge. In long ascending limb of 18 hours, plateau of 48 hours, and descending phase of 4 to 5 days. So total duration of LH surge after HCG injection lasts for almost a week. So after HCG trigger, the susceptible patients are more liable to develop hyperstimulation. HCG can be given in dose of 10,000 or 5,000, leupride in 1 to 2 mg, reticutoril in 0.1 to 0.2 mg, and buserelin in 200 to 500 mg. So before the introduction of agonist trigger, in earlier days of ART practice, every ART practitioner used to suffer from the complications, dreadful complication of ovarian hyperstimulation, has to face this complication. But after introduction of agonist trigger, we can avoid HCG trigger in susceptible patients, hyper-responders, and using agonist only trigger will prevent this problem of hyperstimulation. So apart from preventing hyperstimulation, agonist trigger also improves the oocyte yield and embryo competence. In ART, HCG has been extensively used as a surrogate for LH. HCG binds and activates the same receptors as LH due to its structural similarity and same biological behavior. Thus, it ensures its excellent exposure of the follicle to LH activity after HCG trigger. But in contrast to natural cycle, when HCG is used, there is complete lack of mid-cycle FSH surge. And a mid-cycle FSH surge is equally important for the final oocyte maturation. So until recently, scientists have been relying solely on LH activity dependent trigger for final maturation. Thus, taken it for granted that mid-cycle FSH surge was biologically absent. Since the earlier days of comparison between HCG and agonist triggers, studies have reported retrieval of more number of M2 oocytes and embryos after agonist trigger. So final oocyte maturation in IVF is a complex process which definitely gets benefit from synchronized activity of FSH and LH both. So modification in triggering strategy towards agonist-based trigger is more physiological and has potential benefits towards the oocyte embryo competence. So at the time of trigger, FSH enhances proper resumption of meiotic process final oocyte maturation that we already discussed, and thus adding its clinical value by improving oocyte recovery in pregnancy rates. The specific mechanism needs further exploration, but these findings have introduced the importance of FSH search along with LH search. So major drawback, complication associated with HCG trigger is it has a luteotropic effect. So it is characterized, which leads to development of multiple corporeal lutea and supraphysiological levels of E2 and progesterone, and which results in hyperstimulation. Early onset, OHSS can be early onset when it occurs 3 to 7 days after HCG injection, and late onset OHSS occurs during pregnancy or 12 to 17 days of HCG administration. It can be overcome by avoiding the HCG trigger in hyperresponders or susceptible to develop hyperstimulation and using agonist trigger. So major drawback of agonist only trigger is resulting luteal phase deficiency. Luteal phase can be rescued by a bolus of HCG or intensive E2 progesterone support, but more appropriate is freeze all embryos and transfer in next FET cycle. Dual trigger is when agonist trigger is combined with the HCG given together, and double trigger means agonist trigger is given 40 hours before the pickup and HCG trigger given 34-35 hours before the ovum pickup. So agonist trigger, apart from prevention of OHSS, agonist trigger has got beneficial role in these conditions of the patients. The patients with history of immature oocyte syndrome, history of empty follicle syndrome after HCG only trigger, it is very less likely to develop complication like ovarian torsion. It is ideal in oocyte donation cycles, an ideal trigger for in cancer patients, fertility preservation in cancer patients. So immature oocyte syndrome is defined as more than 25% of immature oocytes retrieved after adequate stimulation and HCG trigger. The etiology is not exactly known, but in various studies it has been suggested to add agonist to HCG, dual trigger, to overcome this in subsequent cycles. Let's have a look on some studies. In a study conducted in 2019, 27 patients with history of premature oocyte syndrome after HCG trigger were given dual trigger in subsequent cycle, resulted in more number of M2 oocytes, more transferable embryos, and ongoing pregnancy rates. So authors have speculated more number of mature oocytes are attributed to presence of both FSH and LH surge, which is not seen in HCG only trigger. Empty follicle syndrome following HCG trigger. The empty follicle syndrome was first described in 1986 in 4 patients where no oocyte found after adequate stimulation and adequate E2 levels. The incidence varies from 0.5 to 3.5%, and it is more often associated with PCOS with antagonist co-treatment and reduced ovarian reserve. So EFS is not a constant condition. It may vary from cycle to cycle. Now, in a study of 43 patients having history of empty follicle after HCG trigger, in subsequent cycle with the same stimulation protocol, HCG trigger, same stimulation protocol, same trigger, 37%, mean in 86% of patient M2 oocyte retrieved. So reason may be cycle to cycle variation in oocyte quality. Several other case reports have some different picture. In study number 1, two cases of empty follicle with long agonist downregulation followed by antagonist received 10,000 HCG trigger. In second attempt, single dose of agonist only trigger used and 9 M2 sites retrieved from 10 follicles. In study number 2, a patient with two consecutive empty follicle following HCG trigger. In third attempt, using antagonist co-treatment, dual trigger was used and 10 M2 oocytes retrieved, followed by 2 good blastocysts and 1 live birth. This is very interesting study. In study number 3, a young woman with normal karyotype surprisingly underwent 7 cycles of IVF using the same protocol with GnRH agonist downregulation, antagonist co-treatment, and given HCG trigger in 4 cycles. In first 7 cycles, in first 4 cycles, empty follicle syndrome was in for 4 cycles. In the subsequent 3 cycles, there are only 1 to 2 immature oocytes retrieved. And point to be noted that the recombinant HCG was used up to 13,000 international units for the trigger. In final successful trial, double trigger was given. Agonist trigger 40 hours before the pickup and HCG trigger 34 hours before the pickup. 16 M2 oocytes retrieved, leading to 11 embryos formation through transferred 9 cryopreserved, resulted in a single live healthy birth. I had a case of PCO having history of ovum pickup twice outside in Gurugram, and follicles were ruptured both the times before the pickup. The reason might be multifactorial, improper timings of antagonist and trigger. I used agonist only trigger along with antagonist co-treatment. 20 M2 oocytes retrieved, 8 blastocyst formation. I did freezole, 2 embryos transferred in FET cycle, resulting in single live healthy birth. So empty follicle, to conclude, empty follicle syndrome is a genuine entity of obscure etiology. It may represent the syndrome of granulosa cell dysfunction in which oocyte meiotic maturation not restored, which does not lead to cumulus expansion, and immature oocyte complexes are resistant to follicular respiration in ovum pickup. These evidence are based on case reports which might suffer from publication bias, but it cannot be ruled out that the FSH surge is required for optimum resumption of meiotic activity and final oocyte maturation, which may not take place in some patients after HCG only trigger. Finally, it is important to note EFS can be encountered also after agonist trigger. Agonist trigger is more favorable in safe in oocyte donation cycles. Donor cycles account for 32 to 35% in many countries, and some moderate to severe OHSS is not uncommon in donor cycles. So using antagonist along with agonist only trigger is more advantageous in terms of safety and efficacy. So the complication of ovarian torsion is also not uncommon in ART cycles. Then increase the volume and bulk of the ovary is predisposed to the complication of ovarian stimulation. So when we use HCG trigger, because of its luteotropic effect, formation of more corpora lutea increases the bulk and volume of the ovary, which predisposes to torsion. While in agonist trigger, ovary regains its original pre-stimulation site, pre-stimulation volume very soon because of immediate luteolysis. So it becomes less likely to develop the torsion with agonist trigger. It is more suitable in fertility preservation patients with cancer patients. So majority of breast cancers are estrogen dependent, and supraphysiological levels of E2 given after HCG trigger will raise the risk further in these patients. So if we use agonist trigger in these patients, it will overcome this by avoiding the high E2 levels because of immediate luteolysis, which reduces the risk in patients with estrogen dependent malignancy. So if we understand the behavior of agonist, understanding the behavior of agonist trigger has developed a new protocols like double stimulation. It consists of 2 consecutive ovarian stimulation. Second one is performed in the luteal phase. So we stimulate the patient from day 2. After 12-13 days of stimulation, we do ovum pickup, and very next cycle we go for second stimulation and do pickup. So agonist trigger is more physiological in first half of the cycle, which leads to rapid luteolysis and ovaries gets to baseline very soon. And researchers have found that the pituitary is able to respond agonist trigger in both follicular as well as luteal phase despite of high level of progesterone. So if we use agonist trigger in first cycle, which leads to immediate breakdown of corpus luteum, so in real sense, in double stimulation, there are two phases back, two follicular phase back to back. However, the FSH and LH induced by agonist trigger was higher in first trigger than in second trigger. So if we plan fresh embryo transfer after second trigger, the trigger should be HCG trigger and not the agonist trigger. So to conclude, the GnRH agonist trigger has got a pivotal role in changing ovulation trigger strategy worldwide, not only for standard patients, but also the patients group like immature oocyte syndrome, empty follicle syndrome after HCG may not always work, oocyte donor patients, patients with poor ovarian reserve, and cancer patients in fertility preservation. And moreover, agonist trigger concept has sparked the development of novel protocols enriching the ART armamentarium for the benefits of present and future IVF patients. So the take-home message is HCG trigger is gold standard and irreplaceable solely. Agonist trigger can be used alone in hyperresponders or susceptible for OHSS. HCG requires to be added to agonist trigger in normal or hyporesponders when fresh embryo transfer is planned. So nothing is the rule of thumb. Whatever we practice now may change after 2, 3, or 4 decades. So selection of right trigger or triggers must be dependent on the patient profile. Agonist and HCG triggers both are complementary. Both are complementary in majority of the normal and hyporesponders. The agonist trigger is more physiological, resembles natural cycle FSH LH search, but because of its disadvantage like luteal phase defect, HCG support with E2 progesterone support is mandatory in all patients. Consider agonist trigger or dual trigger in patients with history of IVF failure. These are the references. Thank you for your patient hearing.
Thank you, Punit. So we have got so many guns in our hand. Towards me, that is agonist. Towards you is antagonist. There is something like nasal. So which gun we have to trigger on which day, on which patient, that will be individualized. Thank you.